Sir, we are able to see and see you well, sir. I am Dr. Srinivas Kumar here, joined by Dr. Ajit Mulasari, sir, and Ajay Kirtane, Anand Ganraj, and Manokar. Please go ahead and introduce your case and present.
Good afternoon, everyone. I am here at the Jagjeevan Ram Hospital in Mumbai. I think Dr. Reddy and Dr. Shishir are my colleagues here. They will introduce this case to you. Dr. Shishir, you can go ahead.
Yeah. Good afternoon, everybody. Here is our patient like this. Is 72-year male, non-hypertension diabetic over last 20 years on medication, irregular on treatment. We had CABG 2016 December with Lima to LED, SVG grafted OM and Ramos, presented to us with history of angina dyspnea class 3 to class 4 over 15 days. And vital stable, however, EC shows ST2 changes in the anterior slits, echo RWMA in the LV territory, EF in the form of 35 to 40, and his parameter in the form of KFT was in the normal level and CBC normal. Going further ahead, we did the angio. We will go ahead further angio, but the overall picture is like the left one, the distal left one mild plaque, and LED is type.
Okay, I mean, there's a little bit of comedy of errors because the case we posted actually to show you guys developed fever just an hour ago. So we had to, and our backup case that we had kept also, we finished it off before we could take up the second patient. So this was a completely unplanned patient. We will show you we repeated the angiographic views. We'll just show you the angiographic views here. Can you go ahead, please? Scene plus. Now, this gentleman had a venous graft to a ramus and a venous graft to an obtuse marginal and a Lima to the LAD. Scene plus. Now, what we saw in the earlier one also was this is tight stenosis in the distal anastomotic site of the venous graft to the ramus. The venous graft to the OM is quite fine. It's normal, nothing major. Scene plus, please. Go ahead. That's the venous graft to the obtuse margin, which is fine. And scene plus. Scene plus. Scene plus. The Lima is there, but it is completely atretic. And scene plus, please. It's atretic, but there is flow down the vessel into the distal LAD. But though it's barely very extremely competitive and barely anything much. Now this is the native left system. The native left system shows that there is a significant narrowing at the ostium of the LAD. Scene plus, two large diagonals, one large diagonal. Scene plus, with two major branches. The LAD can be seen filling up. There's some narrowing of the LAD after the origin of the diagonal, but the diagonal seems to be the larger vessel. So what we actually planned here, can you tell us what would be the strategy of that you would plan out here?
Sorry, what does the right look like?
What is the
right coronary?
The right coronary is normal. It's normal. There are no lesions in the right coronary. It's not a very big vessel, but it's a normal vessel.
Any thoughts, panel? What do people
I
think?
possibly the Lima is strung because the native flow in the LAD is reasonably brisk. I think, I don't know where his ischemia is coming from. Is it from the graft to the OM, or which is the lesion, or is it to the LAD? But if LAD looks pretty critical and the OM looks tight, so I think we should fix both maybe and see. And I'm sure.
Right.
The strategy, right. Ajit, you can tell us what you're planning to do.
Yeah, so what we did was we went ahead and fixed we thought we'll do the graft before we go on live, go on scene plus, and the choices between a drug-eluting balloon I wouldn't like to put a stent in such a small vessel, scene plus, but here there are cost constraints. The drug-eluting balloon is much more expensive than the stent, so we decided we'd use the 2 mm balloon and a 2 mm stent. Scene plus, go ahead. And we finished the scene plus. Go ahead. Please keep going ahead. Keep going ahead. Now, once we finished this, we tried to cannulate the left system. Scene plus, please. Scene plus. And that is where unexpectedly we started having a lot of problems. moment we tried to, scene plus, moment we tried to cannulate the left, I haven't even cannulated the left system, it's lying outside here. Patient developed severe hypotension, broad QRS complexes, bradycardia, had to be given a bit of cardiac massage. And this is the non-selective. I mean, then we couldn't figure out what went wrong at all in this, because we had not done anything. There was no extravasation anywhere to cause hypotension, but the QRS broadened significantly, and we had to put a pacemaker in and revive him with adrenaline, noradrenaline, etc. So luckily, we managed to pull him out of this. And scene plus, then you realize that if you can see, there's no flow in the diagonal. So probably while trying to cannulate it, we have dislodged some plaque, or we have caused a little bit of air embolism.
Yeah, it looks like air because you see how it's to and fro in the distal diagonal.
Yes. Though we took all care, I don't know where. I mean, we probably something in that thing, something escaped, and he was grossly unstable with this diagonal flow being limited.
The other thing that's happened is you don't see competitive flow in the LAD. I don't.
In the LAD, yes.
Which is.
You don't see the competitive flow in the LAD also. So it's we really don't know what happened in this situation. With a lot of adrenaline, NORAD, I mean, intracoronary nitroglycerin, nitroprusside, nicorandil, scene plus. We got a wire into the diagonal in the meantime with the blood pressure, with those levels of pressures. Next, and we managed to re-establish the flow in the vessels. Next. Now you can see that the flow has come back. The competitive flow in the LAD has come back.
You restored flow how did you do? You ballooned it, or what did you do?
No, we haven't done anything. Just with inotropic support, lots of nitroprusside, nitroglycerin into the coronaries. And this is what we were left with.
So it must be air or something like that.
But the flow stopping in the Lima also, whether it was purely because of hypotension, maybe. That's the reason why the Lima flow stopped.
Or air there, and there's no subclavian stenosis, right?
No, there's no subclavian stenosis. No. Okay, so then now can someone suggest what next?
Personally, I would stop. Actually, you fixed the vein graft. You had a bad event. It's now restored and stable.
So now his ST segments have settled down. His QRS is narrowed down.
His ECG normal.
His ECG is normal.
Pressures are normal.
And he's not on any supports now.
Yeah, I mean, I don't know what other people think.
It most likely looks like an air embolism or probably some slow flow from the venous graft.
We don't know. So and we thought we'll treat the ostial LAD lesion, just the ostial LAD lesion. Don't be very thing on that. Would that be okay?
I mean, you can. The thing I don't understand. I mean, I don't truly understand though if that territory is ischemic, because you have flow down the native LAD, you have flow coming down the Lima. There is some intervening disease into the diagonal, but it's not horrible. So it could theoretically backfill. But more importantly, for right now, after that event that occurred, this all was relatively stable. And I mean, the culprit to me seemed to be the vein graft. So before proceeding and doing a lot more here, I guess I said, I probably would walk away and then regroup. But obviously, you know the patient a lot better than I do.
Right. We tried to pass in an IVUS catheter and an OCD catheter. OCD catheter wouldn't go in. Yeah, we want to image and see what's happening. The IVUS catheter, and we did an IVUS actually. We'll show you the images in the IVUS. Can someone show the IVUS, please?
There.
It's really difficult to understand that a small diagonal like that can cause so much of instability.
Well, that was the only compromised flow there.
Yeah, unless there was distal stuff going on downstream. I mean, it's not a small diag. It's a reasonable sized diag, but I agree. I don't think that the patient should be wide QRS, and it seems like it's a more global thing.
And he has a good right cornea, which is normal. So we did an IVUS which shows a significant amount of calcium, almost 180 plus 270 degrees calcium. We couldn't get past the lesion. This was in the mid segment of the lesion.
Yes, sir. I was.
Yeah, but this is stable and chronic, right? That's not the acute
Yeah.
problem.
Yeah. And so if we have to do anything, I will have to rotablate the proximal LED.
Right.
I can't get anything down the vessel.
Yeah, Ajit, I think this is, I think possibly it's air in the diagonal. The diagonal is moderate caliber. I think something must have happened also. Maybe in the LAD we didn't see it, but the diagonal clearly was closed. Now that you got out of it, I would just fix that proximal LED since it's tight. Obviously, your IVUS and rotablade are not, IVUS and OCT is not crossing.
OCT would not show scene plus.
So
Scene
maybe, but I wouldn't go beyond that bifurcation. I would be very, very careful that I fix only the proximal LED.
That's the only thing that I'm planning to do. Scene plus.
And would anybody, because he had slow flow in the diag and the competitive flow in the lima was down and all that, if you're going to fix that osteo LED, would anybody try to avoid rotoblator where you would get more stunning of the myocardium and maybe just try to do shockwave? Or it should not matter at this point?
I think the shockwave won't track, so I think we will have to rotablate if you're going to go with that calcium with no IVUS going through. The only issue is that, you know, if it was clearly air, which was a crawl, I think it will settle down. But if it's something else, then we've got to be a bit careful when we're doing this.
Yeah, that's what, I mean, we do plan to rotablate the lesion.
Now we already put a rotor wire. Now
I exchanged the wire, scene plus. Take this wire out.
But I think, you know, when you're looking at these cases, you know, on your own in your own hospital and maybe not have the same backup there is here, if you just sort of avoided a catastrophic event of the patient where they're having CPR, et cetera, and you've already done an intervention, then it's not wrong to stop, regroup, and then, you know, fight this a different day. Obviously, when you're doing transmissions and multiple people involved and all that, it's a little bit different maybe, but probably shouldn't be. And so I think for many people at this point, resolution and watching would be the right move.
I would agree with that. I would agree with that. But since the patient settled down quite well, I personally thought that the diagonal was, for some reason, it's quite a significant territory for him. And that's one of the reasons why he probably had.
Yeah, this way is here.
So we have the rotablade in place.
we have taken 1.5 bar.
Pressure, please. Yes. Give me a small test. Small test. Okay. So we generally practice a very slow method of rotablation, not the fast checking side. And we normally keep our speeds at about 170 to 180,000 RPM. So I think that's a decent cut.
I think we should have shown them how to do the single hand.
So we have a single operator technique where we can handle the
I think we should
rotablator.
have shown them how to handle single person to rota.
Was that a 1.5, Ajit?
That is a 1.5. That's a 1.5. I'm not very keen on taking a 1.75. I'll see if I can exchange this and take a balloon, a high pressure balloon. Microcatheter, please. Give some Nicoran intracoronary. Where's the microcatheter?
Yeah.
Any further suggestions at this point of time in terms of imaging?
Yeah, I would just see how the balloon comes up and then maybe image and see what's happening. Exchange the wire with a microcatheter and then balloon it and then have a look after that. What's the size and what
Put
is
the
the
wire
calcium?
back into the ring. Keep it straight. Keep it straight.
So just I'm putting the wire.
No, just keep the wire straight, please. Hold the wire.
Yeah.
Hold the wire. Yeah. Thanks.
Give the regular wire.
2 mm syringe, please, with saline.
Give the regular wire.
Give me the regular
BMW. BMW.
BMW wire, please. It's okay. All right.
BMW.
Give me the 2.5 millimeter balloon.
For a trapper, give me the balloon. BMW.
I mean, I still cannot figure out where the air went in from because we had not cannulated the coronary at all.
You want Nicoran, sir? This is Nicoran. You want?
No, wait.
Trapper, 2 mm
No,
balloon.
the air can go
Yeah, it doesn't
pretty
have to be air. I mean, it could be
easily.
spasm, it could be a variety of things, but I mean, air seems most likely, and it can come from anywhere.
2.5
No,
balloon.
give me the indiflator, please.
Yeah.
Give me the indiflator.
Man 2.
Rotate. Okay, go. Wait.
The part that I don't understand is why there was no, there was no competitive filling down the Lima. That I don't fully understand.
Yeah, give me 2.5 balloon.
2.5 balloon.
2.5
Yeah, that's something which even we couldn't figure out. But at that point of time, we were more keen on trying to stabilize him.
Yeah, but that is the wide QRS and the near arrest type status. That's more consistent with something going on with the Lima
Nicoran.
than a
Nicoran.
diag. So I just don't
Right,
know. The whole
right.
thing's bizarre.
Nicoran, please, intracoronary.
Was the blood pressure very low when all that happened? Maybe that could.
It suddenly fell. Before that, it was about 160 to 170, and when this happened, the BP fell down to about 40, 30 to 40.
And associated bradycardia, and we have to put him a pacemaker. QRS become very wide.
Prepare the balloon, please.
No.
No.
Ajit sir, we're afraid we are running a little short of time.
Okay,
We're left with
you
2-3
go ahead.
minutes. You can, tell
yeah,
the plan.
What you can do,
Yeah.
what you can do, Dr. Srinivas, is go to the other lab, and if possible, come back to us. So we'll show you the what we have.
Yeah,
at
we
the end
have
of
1 minute more with you, then we'll break.
it. Okay. Go. Wait. At the moment, the blood pressure is about 180 systolic. The heart, the ECG is quite stable. Okay, go.
Here Give new balloon.
Get me a new balloon, please. There's something wrong with this balloon.
Give my balloon.
Okay, sir. I think you can work in peace,
All right.
and then we'll come back and see the
Come
final
back.
result.
Yep. Okay. Thanks.
Thank you,
Thanks.
sir. Thank.